So it's my pleasure now to introduce a friend and fellow research collaborator, Professor John Bridgewater from University College London, Cancer Institute. John is one of the world's top 2 or 3 opinions in systemic treatment for cholangiocarcinoma and has led some of the major advances and trials for this disease. John, over to you.
Thank you, Shahid, and thanks very much for inviting me, and it's always a great pleasure to be here. Somewhat special meeting, I say it most years, but it's special because you're here. That does change our emphasis, changes our direction, and it focuses what we do, and that's always a good thing. So with that little that preamble. So this is all about genomics and how that helps. So this was a very modest talk by Matt that you heard just now. For every cholangiocarcinoma patient, he becomes the most important person for a particular stage of the diagnosis because he's able to provide us with the genomic picture. And this all emerged about something like 10 years ago. And there was a project called the International Cancer Genome Project where they DNA sequenced. I mean, DNA sequencing takes half a day now in most laboratories. At the time they did this, it took about 6 months to sequence one patient, and somewhat fantastically, they managed to sequence 489 cholangiocarcinomas. And they came up with this horribly complicated diagram. I won't go too much into it, but it shows all the abnormalities that you find. Each one of these little names on the end here is an abnormality. It shows all the abnormalities and what ones they pair with. And the long and the short of it was, it turned out that cholangiocarcinoma was really rather special in terms of its genomics. It was very, very tidy. So some things only paired up with other things. So if you find one thing, you're very likely to find the other one. And they didn't cross over. So some cancers have about 10, 15 of these in their genome. Cholangiocarcinomas only probably have about 2 or 3. And so it turns out to be really rather extraordinary. We don't understand why yet, but it does turn out to be really rather extraordinary. And not only that, this is the liver. So these are the bile ducts where the cholangiocarcinoma arises, and these abnormalities are placed in specific spots around the liver. So you haven't just got what Matt just told you about, an IDH1. You've got an IDH1 abnormality, and these IDH1 abnormalities are in the body of the liver. They're not anywhere else. So really, it makes it. Well, I think it's terribly interesting, and gives us huge clues about how best to treat the patient. How does a driver mutation give you cancer? This is it put very simply. So if you have a gene like this and it becomes mutated, normally the gene controls the cell cycle. Okay, the cell cycle goes, and your cells divide, you lose cells, you get cells. The whole thing happens. Normally in all of us. When you have a mutated gene, you lose control of that cycle, and your cells, there's what we call a gain of function, and your cells then divide uncontrollably. And this loss of control is what makes your cells divide uncontrollably, and essentially it's what makes a cancer sort of grow in size. That's the fundamentals of that. And in cholangiocarcinoma, so this comes out of the molecular testing booklet, which you can find on the AMMF website. In cholangiocarcinoma, there's people with the hilar or distal, perihilar or distal, so that's towards the bottom end of the bile duct. About a quarter of them have something a gene that we can find, that we can try and hit, that we can try and control. More of the intrahepatic people have something we can hit, probably approaching half, and I'll go into a bit more of that. a bit later on. And the first people to really describe this in any detail were, in fact, the French. And I'll go through this. It looks horribly complicated. I'll try and make it as simple as possible. So this was a study called Moscato, and they did what Matt has just described. They put more than 1,000 people through this NGS process. And they found, and in those 1,000 people, 43 biliary tract cancer cholangiocarcinoma patients, and they found 23 abnormalities, and 18 of those 43 people actually got treatment with something. Now, this was a bit of a messy study in that there was no, carefully planned treatment that followed any discovery, and so not perfect, and something that we would not really be very happy with today. But this told us, this whole business that the French did told us two things. It told us that there are more abnormalities in cholangiocarcinoma that we can hit. We sort of know that already, but this confirmed it. But also that if you give patients with cholangiocarcinoma targeted therapies, they work better. They definitely work better. So 6 out of 18 people had what we call a response, described earlier by somebody, where your cancer shrinks to half the size. That's a response. 6 out of 18, that's actually quite a lot. That compares to 1 out of 10 for the non-cholangiocarcinomas. So the stuff that you can, so not only can you hit more genes, but it tends to work better. So this was hugely, hugely encouraging for us when we started working at this some years ago. And these are the drugs that they had, but we'll come to that in just a minute. And over the years, we've now generated really a very, very whole pile of data about how well this stuff works. So on the far left here, and this is on the far left here, you have the trial that we did, ABC6, looking at chemotherapy, and chemotherapy is modestly effective. We always said this at the time. Juan Valle and myself ran this, and it's still the international standard for people, but we're not terribly proud of it. It isn't great, it isn't a brilliant result for people. Compare that to patients who have IDH1 mutations. They do much better. Compare that to people who have BRAF mutations. They do better still. And then on the far right here, these FGFR2s, they do really well. And this was this was using what we would consider to be relatively old drugs now, pemigatinib. Futi's not too bad, but these are now considered to be old studies, and people on the right here, they really did much better than we expected. And so this is now the list of, and this is the trial that we have coming up, which is ABC10. And these are the list of all the things that we're looking for, that we're hoping to treat people with. And you see it's quite a long list. It's a list that's a lot longer than that which you get if you don't go into a trial. So these are the, sorry, I've slightly messed up my colors here, but these are the ones I put in red dash, sort of brownie red, are the tests that you get as part of NHS process, standard NHS process. These are the tests that you get on the NHS directory. So we're adding all of these other green ones in, and I think that's a really important thing and helps us to increase that share. So, half of intrahepatic cholangiomas, this is going to increase that and really try and increase the number of people that we can target with these treatments, because we think it works better. And so I thought I'd finish off just by illustrating the process of what somebody has to go through and what it's like, and the roller coaster sort of scenario is not inappropriate. So this is a man who was 64, and he had an operation to take away his cancer in 2019. It recurred. and he had standard chemotherapy with what was the standard at that time, cisplatin gemcitabine, and then it got worse in February of last year. And he came to us and said, have you got anything else? I've heard about FOLFOX. Have you got anything else? And so we went through a number of tests, and this was not for the faint-hearted. Okay, this took some effort, and it needs some, needed really, and the patient was fantastic. I said, oh, you need to do this, and he went, all right, go ahead and do it, and you need to do this, all right. So first of all, we did this. We did a garden, what Noreen told us about just now, and that didn't show anything. So that just simply means that for some reason he didn't have many cancer cells in his blood. Then I got him something called foundation medicine testing on one of the studies that we were running at the moment. So the relay study gave us free foundation medicine testing, so I did that. And he had this. He had an MDM2 amplification. Now, MDM2 is, there's a cartoon coming up. It's a gene, and we are interested in MDM2. But it was equivocal. So we then had to go back to his biopsy to do this FISH test that again Matt told us just now about, and it confirmed that the MDM2 was amplified. And this, roughly speaking, is how it goes. So this is what we call copy number on the side here. So it's the number of copies of that particular gene that you get in your cancer. And actually, you can lose copies of genes as well as gain copies of genes. But anything higher than this line here, normally it's something like 6 or 8 times, means that there's something going on. This is a bad guy here. And sure enough, he had this is chromosome 10, I think. He had MDM2 amplification on chromosome 10. And so he's gone into this study. So this stuff, it's got a name now that's actually probably more difficult to say than the number, BI number, is a drug that attacks this amplification of MDM2. So MDM2 prevents this other stuff, P53, from controlling cell growth. And if you have lots of MDM2, which if you have lots of copies of the stuff you do, then you get uncontrolled cell growth. So it's a sort of real target. It's what we call a good target. If you have this stuff, this BI drug that inhibits the MDM2, you get apoptosis, and the cancer doesn't grow out of control. So that's the principle of this stuff. And so our patient's been on it for a bit. Just a little bit about clinical trials, because that was what was said. The trial on which we've used this stuff is a phase 2 trial where we're looking at how well it works. And the objectives really are to evaluate the efficacy of this stuff. And so that's what a patient goes through to get on a targeted clinical study. It's not straightforward, it's not simple, but really it can work. It can work very well. It's not guaranteed. It can work very well, and this is what I spend my whole time doing, trying to get people into trials like this to see whether it works better. And really, the whole idea here is to add to the number of targets that we can hit. So this comes again from the AMMF booklet, and looks and details a number of these things that we can hit or try and hit. And the intention really is to add to these. So this was 50%, roughly speaking, 40 to 50%. You add MDM2, which is 7% to that. There's some other stuff coming along, which inhibits PMRT5. It's horribly complicated. And that will again add to the number. So bit by bit, we're increasing that. We're turning the dial around. We're turning the dial around to increase the proportion of people that we can offer helpful treatment to. So, biliary tract cancer is genomically diverse, but it's got more what we call actionable alterations than a lot of other cancers. if you're a patient, make sure you get tested, and it's the best test you can get. Some tests are better than others. And then make sure that your case with that test result is reviewed at a center who know about these tests. This is fairly niche stuff here, and not, as we've heard already from people speaking this afternoon, you need to get to somebody who knows about it. These are all the people that fund me. Thank you very much.